At this point, we'll move into the next part of our talk. We have Dr. Mahmood, who's going to be talking about a journey through the timeline of therapies for stage 4 melanoma. Dr. Mahmood, he's the Associate Director of the Melanoma Multidisciplinary Program and is a medical oncologist specializing in the management of patients with melanoma and advanced skin cancers. We recruited him from the University of Arkansas, and he's been with our program for the past 3 years. He's been a great addition to the program. We're really happy to have him as a partner with me in treating patients. And I will now pass the baton to Dr. Mahmood to discuss treatment strategies for stage 4.
Thank you very much, Mark, for this kind introduction, and good morning, everyone. I would like to thank AIM at Melanoma organizers and staff for giving me this opportunity to talk to you today about cutting-edge therapies that we have been using for the last 10 years in managing advanced melanoma. And I'll share my screen right now. So I'll, within the next 15 to 20 minutes, I'll take you in a journey through the timeline of breakthrough therapies in metastatic melanoma. Let's start about some of the history. If we go back to the early 1900s, surgeons who operated on patients with cancer realized or noticed that in a subgroup of patients who developed a post-operative infection, that the cancer is melting away. And that gave hint to Dr. William Coley in the middle here. He was the orthopedic surgeon at Memorial Sloan Kettering in New York City. And he developed a toxin, and it was called back then Coley's toxin. And it was a mixture of bacteria and bacterial products. And what Dr. Coley did, he injected this bacteria into the muscle of his patients with advanced cancer. And actually it worked. There has been some cure of some patients with advanced disease that have been cured by injecting the bacteria into the deltoid muscles. And it made it even a headline news in New York Times back in the 1908. Well, there has been a lot of criticism for his methodology. And back then there were a lot of enthusiasm about radiation therapy and chemotherapy. So the so-called Coley toxin back then, because of all these factors, it just didn't make it to practice. However, knowing what we know now about the important role of our immune system in fighting cancer, honestly, Dr. Coley, with his neat experiment, he deserved to be named the father of immunotherapy. It took us until the 1970s where we, researchers started getting interested in high-dose IL-2. And IL-2 is a T cell or immune cell growth factor. So it stimulates the whole population of your T cells in the body. And when they tested high-dose IL-2 in patients with metastatic melanoma, meaning the melanoma that's spread to other organs, we find here that most of the patients don't derive benefit, they will die. But if you look at the tail of the curve, it started flattening. And it's this flattening of the tail of the curve, about 10% of the patients, they would derive a long-term remission. It's translated to a cure from high-dose IL-2. And for that reason, before the 2011, high-dose IL-2 was the main treatment for patients with metastatic melanoma. And it was approved for patients with metastatic renal cell carcinoma, kidney cancer. The problem with high-dose IL-2, it's toxic, it's difficult. Patients need to be in the hospital for 5 days, getting this doses every 8 hours. They could have low blood pressure, they could have fluid buildup in the lungs, shortness of breath, and it was a very, very difficult treatment. It took us 3 decades to realize that stimulating the immune system by using high-dose IL-2 alone is not enough unless we remove the brakes from the immune system, the brakes from our T cell. And in the next 2 slides, I'll be talking to you about checkpoint inhibitors. So let's look at here. The cell in yellow is your T cell. It's your immune cell. It's the cell that defends you against bacteria, viruses, and also cancer. And the cell in light blue, it's called the dendritic cell. And this is the most proficient antigen-presenting cell in the body. The function of this cell is to present piece of the tumor, a protein. It presented to the T cell and tell the T cell, please get active against this cancer. We need to kind of fight this cancer. Well, what happened is, look at this receptor here, they're called the CTLA4. This receptor is on the surface of your immune cell. And if it gets overexpressed, this CTLA4 acts like a brake. It puts the brakes on the T cell. So you've got your T cell there, but they are not functioning and they can't fight cancer. So the CTLA4, which was the first checkpoint to be discovered by this scientist, James Allison, and as a result of this discovery, he won the Nobel Prize of Medicine in 2018. And that led to the discovery or the development of the drug called Epilimumab, or patients may know it as Yervoy. And when Yervoy what does it do? It basically removes the brake from your immune cells, and the immune cells will function back again. And when it tested in patients with advanced metastatic melanoma, the long-term remission occurred in 21%. And this is a pooled analysis data of patients with advanced metastatic melanoma stage 4 who were treated with Epilimumab, either in the frontline setting or after they failed high-dose IL-2 or chemotherapy. As we can see here, some of the patients, they don't derive benefit. They die from stage 4 disease. But you look down here at the tail of the curve, we've got this flattening, and it flattens at 21%. So 21% of the patients, they derive a long-term remission, translate into cure. And that led to the approval of Epilimumab in 2011 to treat patients with advanced melanoma. This is an important landmark study that opened really the gate to the revolution that we are having and to all these wonderful drugs and the immunotherapy revolution, not only in the management of melanoma, but in the management of other cancers as well. The other checkpoint inhibitor is called the PD-1. And the PD-1 is a receptor on your immune cell. The yellow cell is your immune cell, or the T cell. This is a cancer cell. So the cancer cell takes advantage of this receptor, it's called the PD-1, and send a ligand, a PDL1. When it binds to PD-1, it suppresses the function of your T cell. So the PD-1 again acts here as a checkpoint. It acts as a brake, and it puts the brakes on the T cells so the T cells don't function. And this PD-1 receptor was discovered by Dr. Honjo from the University of Tokyo. And as a result of this discovery, he won the Nobel Prize of Medicine, or he shared the Nobel Prize of Medicine with Dr. Allison in 2018. And the discovery of the PD-1 receptor led to 2 approved drugs in the management of melanoma: Pembrolizumab, or patients you may know it as Keytruda, and Nivolumab, you may know it as Opdivo. And when it was tested in the clinical trials, long-term remission translated into cure occurred in 40%. We're not talking anymore about 21%. We're talking here about 40% of the patients. These drugs were approved in 2014, as you can see here. The Checkmate 067, this is a randomized phase 3 clinical trial where patients with unresectable stage 3 melanoma or advanced metastatic disease were randomized to one of 3 groups. A group got the Nivolumab plus the Epilimumab, another group got Nivolumab alone, and the third group in gray, they got the Epilimumab. And as you can see here, that the 5-year overall survival is 52% for the patients who got both drugs, Epi and Nivo, 44% for patients who got Nivolumab alone, and 26% for patients who got Epilimumab. And that led to the approval of the combination of Epilimumab and Nivolumab for the treatment of patients with metastatic melanoma. So as you can see here, this advancement, this revolution, we start from 10% cure, and after 2011, we go to 21%, 40%, 52%. This is a patient of mine. He had a metastatic melanoma. He presented April 2018. This is a CT scan of his abdomen. As you can see here, this organ is called the liver. And inside the liver, you have these hypodense lesions scattered in the liver. These lesions were biopsy-proven metastatic melanoma. This is an MRI of his spine. And as we can see here, that there are hypodense lesions, these big lesions scattered throughout the spine. So when should I use Ipi-Nivo and when should I use Nivo? I mean, the prior trial that I presented, one patient may ask, but my oncologist started me on Opdivo alone or Keytruda alone. That's fine. This is what's called the art of oncology and the art of treatment. You absolutely have to stick with your oncologist, talk to them. The oncologist will review your radiology results, your labs. He will examine you, and he or she will examine you, and then will basically give you the best approach to how to handle metastatic melanoma. Sometimes we use Ipi-Nivo, and sometimes we can go by Nivolumab or Pembrolizumab alone. Fine. So this patient, he has a bulky disease. He had a lot of disease. He was very symptomatic. He was losing weight. He had a high LDH level. These are, when the patient presents with this clinical picture, I prefer to start with Ipilimumab and Nivolumab. And also patients with metastatic melanoma to the brain, we got to be aggressive and go with 2 agents rather than 1. He received 2 cycles, and after that, he developed immune-mediated colitis. He started having diarrhea, abdominal cramps, abdominal pain. He got to the hospital after 2 cycles, and in the hospital, in the ER, they did for him a CT scan of the body. And look at the CT scan. So we look at the liver, and the liver lesions already going away, already decreasing in size after only 2 treatments of Ipi-Nivo. Look at the spine. The spine lesions started to get better. And if we look at the last images here, in August, we see that the liver is absolutely clear of tumor and the spine is absolutely clear of metastatic melanoma. Now I'm shifting gears here to talk about an agent, an oncolytic agent. This is the first oncolytic agent that is approved in oncology, and it's a drug called TVEC. TVEC is a genetically engineered herpes simplex virus. So when we inject TVEC into the melanoma lesions, it goes specifically inside the melanoma cell, it triplicates, it leads to local destruction of the melanoma cell, and it induces a local inflammation. It invites all these T cells, all these dendritic cells, and then hopefully your T cells will get activated against melanoma, and it will have even a systemic effect. So those T cells will go, they patrol the body, they started looking for these melanoma cells. And as we can see here, so TVEC in this trial was compared to GM-CSF, which is an immune stimulant and a drug that we have used in the past, in the old times, it was used a lot in research and in patients with melanoma. And as we can see here that we have an overall survival benefit. But when we look at the subgroup of patients, the patients that derive the best benefit are the ones that have metastatic melanoma to the lymph node, or they have what is called in-transit disease. And I'll show you in the next slide a case of a patient who had in-transit metastatic melanoma to explain to you what does it mean in-transit disease. While look at D figure here, that the patients who have advanced melanoma that spread to the liver, spread to the lungs, spread to the brain, they will not derive benefit from TVEC. So TVEC is good for a local disease. It's really not good for metastatic disease, although there are some clinical trials combining TVEC with other drugs, other checkpoints that we just talked about, and these clinical trials are showing encouraging results. So this is a patient who had an old melanoma that was removed, and this is his old surgical scar. He had this melanoma a year before he presented to us. And after he presented to us, we can see this nodules scattered around the old incision. And this is what we call it in-transit melanoma. And for this in-transit melanoma, we see it here. For example, we see it in the scalp. You know, some patients may have a nodule in the scalp that surgeon go and remove it. It comes back again. Surgeon go and remove it, comes back again. I got a call from the surgeon, said to me, what I'm going to do for this patient? It's just happening again and again. TVEC. TVEC is great to apply in these clinical scenario. And this is what we have done. Now, before we gave him TVEC, he was complaining about this blackish scar, or it was draining, it was painful. So Dr. Gimble took him to the surgery and just cleaned that open wound or ulcer. And after that, you know, still you can see this in-transit nodules right here. And we started injecting these nodules with TVEC. And after that, he derived a complete response from just a local treatment that has a minimal side effects. And in most of the patients, they go home, and some of the patients may tell me, I had a fever for about a few hours and went away. I took Tylenol and whatsoever. It's very, very benign and a good treatment for local melanoma. And here we go. TVEC was approved in 2015. Now, the last slide, I'm going to be talking about the BRAF mutation. So this pathway, we call it the MAP kinase pathway, and think about it as an electrical circuit, a power circuit. Every cell of your body got to have that circuit. And this circuit is responsible for our cell survival, growth, and proliferation. What happened in melanoma cells? At the level of this gene that called the BRAF, 50% of patients may have a mutation. And this mutation, I explain it to the patient that think about it like an engine that is just turned on all the time. It can't turn off. Think about it as a power grid, just keeps, you know, pushing this electricity. The electricity is turned on all the time. And that leads to increased proliferation, an aggressive form of melanoma that spread, increased invasion, and so forth. This BRAF mutated melanoma is a type of melanoma that typically go to the brain, is an aggressive form of melanoma. But fortunately, we discovered drugs that they can block this BRAF V600 mutation. And when they combine them with other drugs, and there are these drugs they call BRAF inhibitor that blocks the BRAF gene, and MEK inhibitor that blocks the MEK gene, and they are pills. And when we give them to patients, they work great. So this is a patient with metastatic melanoma. This is a PET CT scan. You see this widespread metastatic disease, black all over the liver, all over the soft tissue of the body, and you know, in the lymph node, in the lung. And she failed Epilimumab and Nivolumab. She had a BRAF mutation. She was extremely sick. She was actually placed on hospice because they have given her in the past adjuvant treatment. She had received adjuvant targeted therapy, and she had some side effects. Well, we got to understand that this targeted therapy, if you have a side effects to a combination, that doesn't mean you cannot try another combination. So when she came to us, I think she has had in the past the dabrafenib and trametinib in the adjuvant setting, meaning after her surgery. And the oncologist stopped that back then because she developed fever and chills. And these are one of the common side effects from the dabrafenib and trametinib. Then went on to get Epinivo, and then they claimed her as hospice. And then we gave her the Braftovi and Mactovi, or encorafenib and binimetinib, and she derived a complete response. She did extremely well. This targeted therapy works in more than 80% of the patients, and it works fast. I mean, if the patient is sick within days, they will feel better. Within weeks, the tumor started going away and melting away. The problem, though, with targeted therapy, as I tell my patients, is resistant. You know, the body and the melanoma start learning to be stubborn to targeted therapy, so they may work for about a year to 2 years, and then the melanoma will come back. However, we're learning from long-term data that we have about a third of the patients, about 25% of the patients alive 5 years taking their targeted therapy and incomplete response. And we're learning more about this subgroup of patients. So here we go. I mean, we have 3 combo oral drugs. One of them called the brafenib trametinib, again, BRAF MEK inhibitor, vemurafenib, cobimetinib, again, BRAF inhibitor, MEK inhibitor, and encorafenib, binimetinib. And there's a lot of research combining this targeted therapy with immunotherapy. And as a result, we have a new approved triplet therapy, which is called atezolizumab. Think about atezolizumab like Keytruda, like Opdivo. And when it was combined with vemurafenib and cobimetinib, the study was positive, and it was approved in 2020. So this is the timeline. This is very exciting. I tell my patients, if you came before 2011, the majority of patients, unfortunately, with melanoma, they would die. But right now we are providing cure, we are providing hope. And we tell patients the goals of treatment now is curing melanoma. And thank you for listening to the lecture, and I would welcome any questions.